Welcome to the lecture for Crisis Intervention. We'll be covering two chapters in this lecture, Chapter 11 on HIV and Chapter 12 on caregiver burnout. Starting with Chapter 11, looking at some definitions to begin with. AIDS, of course, is acquired immune deficiency syndrome, or may also stand for kind of a related term, acquired immunodeficiency syndrome. Either way, that's a disease of the immune system, which is caused by HIV, right? Which HIV is, excuse me, the human immunodeficiency virus. So the virus causes the syndrome. The syndrome is a collection of symptoms. And Aguilera talks about revisions to the surveillance criteria used by the CDC that occurred in '93. Really, those aren't even still the criteria that are meant to be used by physicians. They're meant for the CDC, and also they've been updated again. So it's helpful to kind of talk about them in terms of understanding the difference between AIDS and HIV, because they're not exactly the same thing. And really, the CDC is getting away from using the term AIDS and just talking about different stages of an HIV infection. And really that's because the word AIDS really scares people. It has a lot connected to it, and for whatever reason the acronym HIV seems to be less charged to people. So we talk about different stages of HIV. Right? Stage 1 HIV is when you're positive for the virus, but there are no AIDS-defining conditions, which are typically secondary infections that are common among individuals who have compromised immune systems, like people who have what we used to think of as full-blown AIDS, or also people that have lupus or other kind of immune system problems get these secondary infections. And those secondary infections, in this context, are called AIDS-defining conditions. So you don't have any of those conditions, and also your T cells, one type of white blood cell, are still kind of in the normal range. So it's kind of the early stage. So as I said, no AIDS-defining conditions. Stage 2 HIV, still not any AIDS-defining conditions present. And with the advent of some of the newer medications, people are staying in stage 1 and stage 2 much longer than they used to. But the transition from stage 2, from stage 1 to stage 2, still no AIDS-defining conditions, but now the T cell count starts to drop some, so it's below normal. So the virus is gaining ground, if you will, and doing more damage to the body, and the immune system is becoming more compromised. And then stage 3 HIV is what maybe was formerly referred to as full-blown AIDS. This is when your T cell count drops significantly, and or you have AIDS-defining conditions present. So the immune system has been compromised, and now you're developing these other conditions. Okay. So now that we've gotten those kind of definitions out of the way, we can talk about how it relates to crisis intervention. And really, there are two kind of broad categories of crises that we may think about related to this. One, the crisis of encountering the situation where a client might believes I might be HIV positive, so they don't know yet, and so that's their crisis, that they might be HIV positive and they don't know what to do. And then the other group of experiences would be people that do know that they are HIV positive. So kind of your pre-test group and a post-test group in terms of HIV testing. Those might lead to different crises. Right? Let's start with the first one first. The fear that one might be HIV positive. So when we're talking about a crisis, usually we're assuming that there's some sort of reasonable fear that they're HIV positive, right? So they have some reason to believe that they may be infected. Either they learn that a previous partner is infected, or maybe they experience some sort of high-risk behavior. It could be a healthcare worker that got a needle stick, and the patient either is known to be HIV positive or is an unknown HIV status, or maybe they experimented with intravenous drugs, but for whatever reason they have some reason to believe they might be positive. When this happens, usually there's a pretty good degree of ambivalence about getting tested. And some people think, oh well, no, why would you even be ambivalent? Of course you want to get tested. Well, you say that, but in this situation, there's kind of that if I get tested and find out I have it, that would be awful. And as long as I don't get tested, I'll never have to have that horrible experience of knowing that I have HIV. Right? And the other thing you might kind of tell yourself, trying to talk yourself out of getting tested, well, I might not have it. Why go through the anxiety of getting tested? Or, what if someone sees me or finds out I got tested? Then what will they think about me? So it's not as clear cut as, oh, if you think you might be positive, oh, it's an easy decision to go get tested. For some people, it might really lead to a psychological crisis. With these individuals, two kind of main groups of goals to be working on. Big one would be education, right? Knowledge is power. So educating them about testing. So how, when, and where can they get testing if they choose to pursue that? And even if they are concerned about going somewhere, there is an FDA-approved mail-in test that you can do at home, where you wouldn't even have to go to a clinic to get tested. You send off the stuff that's sent to you, and there you go. In terms of is testing confidential, or is it even anonymous? Well, yeah, most states, 45 states in the U.S., including Texas, offer anonymous testing, and the remaining 5 states offer confidential testing. It's much more acceptable and common now than 20 years ago. About half of sexually active adults surveyed reported that they had gotten tested at some point in time, which is a significant increase from earlier surveys. So that's a good thing. So people, a lot of people are educated about it, but your client may or may not be. You want to educate them about HIV, about the advantages of early detection. We know that if you detect early, and you're in stage 1, you have all these treatment choices. As you go to stage 2 and stage 3, the treatment choices shrink, right? And the likelihood of a good outcome shrinks. So educating them about the advantages of early detection, what happens if detected late, educating them about the potential risk of infecting others. Like, okay, you don't know if you're HIV positive. If you're deciding about whether or not to get tested and what to do, here are the things. If you might possibly be HIV positive, here are things that, if you did these things, you would be putting other people at risk, right? And how to reduce the risk of transmitting infection to another person. Along those same lines, educating them about risky behaviors. Help the client identify what things they're doing or have done that put them at risk. So are they having unprotected sex or using intravenous drugs with needles that they don't know are sterile, and obviously address strategies for reducing the risk. Whether or not they get tested, you want to reduce the risk of future exposure if they're possibly not HIV positive at this time. So of course you need to know about how to reduce risk to be able to educate them about that as well. And then the other big goal, obviously, would be for them to make some decision about testing. So they have to resolve this kind of crisis by deciding, yeah, I'm going to get tested, or no, I'm not, and I'm going to figure out a way to deal with these anxious feelings. Right? And the key thing here, kind of ethically, is to respect the client's autonomy, which might be harder than you would think, especially if they decide not to get testing. It's hard not to abuse your power here to influence them, because obviously from a kind of healthcare standpoint, it's in their best interest to get tested. From a society standpoint, it's in everyone's best interest for individuals to get tested who might be at risk, to reduce the spread of infection and prevent epidemic. I think we've talked before about if they have a partner who they're currently sexually active with who isn't HIV positive as far as I know, and they think they might be, that struggle of, well, you don't know if they're HIV positive, is there a pressure to get them to get tested or tell the other person that they might be positive. And really, the thing here that you want to do is really put an emphasis on rational thought when making decisions. If they're in crisis, okay, let's marshal all your ego resources, and okay, you have this fear and this fear, and let's look at how reasonable these fears are, and if choosing not to get tested or choosing to get tested is a rational response to that fear. But it is possible that they could rationally decide not to get tested. It's hard for me to imagine too many cases where that could happen, but it is possible, and those are the cases that it's really hard not to abuse your power and to respect clients' autonomy. Okay. Now the other big group of crises will obviously be when somebody finds out that they are in fact HIV positive. Again, obviously education is huge here too. You need to be able to provide information and good referrals to medical personnel. Again, you don't have to be a medical professional yourself, but you need to be able to refer to the appropriate people. Excuse me. There's some unique aspects to this crisis I wanted to address. One compared to some other crises we've talked about. This is one where people may really be facing their mortality, or at least think they're facing kind of imminent mortality issues. Because education is here to get a realistic perception regarding how imminent death is, which really depends a great deal on the stage of infection that they're at and what medical financial resources they have. People are living longer than we really thought possible with HIV infection from what we thought a couple years ago. Which there's not a cure, but the predicted lifespan is much longer than what it was when the epidemic first really took hold. But you need to. That's one thing you'll probably need to assess for and talk about. Another thing is looking at the reaction of others, which may include fear of contagion. So if they're HIV positive, and if they need to decide whether or not they're going to share that with other people in their lives, and then you need to help them deal with how other people will react to them sharing that information, and how they're going to react to other people's reactions. Which again, and the big part of that, is education about actual modes of transmission and ways that you can't transmit HIV. Excuse me. Another thing to think about would be homophobia, and kind of just the association of HIV with homosexuality, which it's and this is kind of a cultural association. It's not a scientific association. Homosexuality doesn't cause HIV. HIV doesn't cause homosexuality. But that is a group that is at risk because many people in that group, at least among for homosexual men, if they engage in anal sex, that's a high-risk behavior for the transmission of HIV because of the biological nature of the sex. Heterosexual couples that engage in anal sex are also at high risk. They're at the same high risk of homosexual individuals who engage in anal sex. So it has nothing to do with the sexual orientation. Doesn't cause HIV. It's a particular sexual practice which is more common among individuals with a certain sexual orientation. But because there's an association there, even if the person isn't homosexual, if they find out they have HIV, and regardless of how they got it, if it was through anal sex, drug transmission, blood transfusion, really rare these days, many people may assume or wonder about their sexual orientation, and so that's another thing you may want to talk with them about in terms of anticipating the reactions of others, and then their own reactions to their HIV status and what it means as part of their identity. And for you as a counselor, this is also kind of brings up some diversity issues in terms of if a counselor has kind of unresolved issues related to homophobia or heterosexism, they may not be effective in working with individuals who are HIV positive, especially individuals who are HIV positive and homosexual. So if you're going to be a counselor, you need to figure your stuff out and find a way not to impose your values on a client, because a client puts a lot of trust in their counselor, and they can be really profoundly damaged by rejecting behaviors. You tell a client, well, you have HIV and you got it this way, and I couldn't work with you because I have some things, and it's me, it's not you. That's still going to be profoundly damaging to a client. If you were to do that, even if you said, okay, I need to refer you out because it's the ethical thing to do, still that is a rejection in a therapeutic relationship, which potentially could be damaging to a client. So counselors need to figure out their own stuff before becoming counselors. Okay, let's move on to chapter 12 here and talk about burnout. And this chapter about burnout is really helpful in two ways, in my mind. One, clients may present with burnout. So you may be seeing clients who are help givers, caregivers, who are experiencing burnout. But also, two, you obviously as a counselor are at risk for experiencing burnout because of what you do. So in terms of what is burnout, lots of different definitions, but the one I think fits best is, it's a pattern of thoughts, feelings, behaviors among some professional caregivers, that are characterized by a couple things. One, being emotional exhaustion. That's one of the things I want you to be thinking about that we'll talk about in class is, well, how do you define emotional exhaustion? What does it mean to be emotionally exhausted? Also characterized by depersonalization of others, and this could be of supervisors, of colleagues, of clients, where you start seeing them less as people and more as objects that are either in your way or demanding something or needing something, but not fully realized individuals. So emotional exhaustion, depersonalization, and then also quite commonly a perception of decreased effectiveness in helping. So when you're feeling burnt out, you feel like, oh, nothing's working, I can't do anything, nobody gets any better. Kind of pessimistic thinking about the effectiveness of what you're doing. So what things put individuals at risk for burnout? Talk about two things: characteristics of the helper and characteristics of the work environment. In terms of the helper, one that people are sometimes surprised to read about is unrealistic optimism. Right? So when people go in thinking, I'm gonna every client that I see, I'm gonna connect with them and I'm gonna change them, and they're gonna be so happy and so grateful for what I've done to them, for them, and it's just going to be wonderful, magical experiences all the time. And as long as I try hard enough, I can help everybody. That's an unrealistic approach to what we do. And if you go in that way, that really puts you at risk for burnout. Having a difficulty asking for help, admitting that you struggle. Because again, as we'll see, one of the best ways to prevent burnout is to not get isolated, to reach out to others. People that can't reach out end up being alone and feeling ineffective and overwhelmed. A third thing would be people who have difficulty maintaining healthy boundaries, psychological boundaries, physical boundaries with clients. And some clients probably more difficult than others to keep healthy boundaries with. And then also not surprisingly, having an unsatisfactory life outside of work. And this frequently comes from if family's not going well, or school, or church, or whatever else. If those things kind of suck, then you focus everything on work. And if work becomes your main focus and the place that you look for love and esteem and meaning, that's red flags. That's danger for burnout, and also danger for some other things in terms of ethical practice. Okay. But in terms of risk of burnout, characteristics of the work environment, lack of peer support, as I said before. If workers are socially isolated to where you don't have any time to meet with your colleagues, even if it's just for lunch or catch them in the hallways, greater risk of burnout. It's good to be able to talk and vent frustrations with peers, because people who aren't counselors really can't understand as well. And you can vent to a non-counselor loved one, partner, husband, wife, and that's good sometimes, but it's not the same as talking to somebody else who's doing that same work and really has a better understanding of the frustrations you're struggling with. So peer support is good, but one kind of thing to know here is peer support is good if it's quality peer support, because peer contact can be corrosive as well if it's only complaining. So if you complain to them and they complain to you, that doesn't seem to be a good thing. If you complain to them and they listen actively and say supportive things, then that's good. If you complain and they say, yeah, you're right, all clients are stupid and nobody's ever going to get better, that's not going to be helpful to you. So being isolated is not good. Being around peers is good if they're kind of quality, supported peer interactions. Also, the job structure can play a role. If there are vague job roles, if you're not sure what your responsibilities are, that puts you at risk for burnout. Primarily because when you're not sure what the roles are, people in our profession tend to take on more than they should, right? We end up setting inappropriate boundaries. If we don't know how much we're supposed to do for clients, we do too much. Tends to be a kind of a part of a personality factor common to counselors. Also, if there's kind of poor lines of communication, again, this is not only among colleagues but also between your supervisor and yourself. That puts you at risk for burnout. And if there's not a kind of mechanism that's transparent and reliable for you to change the organization you're working in, to kind of give feedback if things aren't working well. So they've got you working too long hours or not enough resources, and you have no way of changing that, nobody to kind of make suggestions to. That increases the risk of burnout as well. Aguilar talks about stages of burnout. We'll talk a little more about a process, with the recognition that not everybody will go through all the stages, and they won't necessarily go through them in a clear sequential order. May skip some stages, but this kind of gives an idea of what might happen for some people. It's again not something that happens overnight, but tends to be a process of becoming burned out. So it's not like, oh, I'm fine, and then one day I'm burned out. It's kind of getting more and more burned out. Related to that kind of unrealistic optimism, the first stage, if we think about these as stages, is enthusiasm, right? So typically this is when you're really, everything's going to be great, when you have unrealistic expectations. If this is a client who you're dealing with in burnout, they're probably not going to come to therapy, if they're still in the enthusiasm stage. If they do, they're probably coming for something else, and you want to just make sure and encourage realistic expectations without encouraging negativistic or pessimistic attitudes. So you want to keep them from thinking, I can save everybody, but you don't want them to think, I can't save anybody, right? So find that realistic middle ground. Stagnation comes next. This is after that initial burst of energy has fizzled, and the person may begin to question their earlier assumptions about their work. Well, maybe I can't really help everybody. Still, I'm not going to present for therapy if they're in this stage. This might be just kind of a necessary correction that people go through if they have kind of unrealistic expectations. They kind of become stagnated and then return to kind of this baseline appropriate working level. But it could also be the beginning of a slide downward into the next stages. The key to helping them at this point is to shift the role of their job that their work has in their lives. Encourage them to be sure and get their needs met in a variety of other ways. It's like this job isn't what you thought it was, but it's not as bad as maybe you're starting to think either. And maybe you're relying too much on this job for certain things. And let's talk about other ways that you can get those needs met. Now, if things don't turn around for them, they may proceed to the frustration level, obviously where they're feeling frustrated. So they still want to be able to help, but they feel powerless to do so for a variety of reasons. Maybe they're thinking the clients can't change, won't change. Maybe the work environment won't allow me to do the things I know I can do to help these people. This is the most likely stage for someone to present to therapy, to you, and if they're a helper who's struggling with this, they'll come in at the frustration stage. Fortunately, there's still some kind of energy at this stage, so they haven't given up yet. So that energy can be used productively if channeled, right? So help them advocate for organizational change, help them engage in other behaviors that will get their need to have an impact met. And it may even be something which may sound counterintuitive, like, have you thought about volunteering at a soup kitchen? They're feeling frustrated because they can't help, and you tell them to help more. Well, no, you tell them to help in a different way where they can maybe see tangible results of their helping, because in our profession it's often hard to see the results right away, and that's part of what leads to the frustration. So don't stop counseling, but do some other stuff too, that where you can see the results a little more quickly. What you don't want to do is let them just disengage and withdraw from the situation, right? And that may be their temptation. I'm getting frustrated, I'm just going to pull back. So you may need to kind of increase their frustration a bit to prevent them from slipping into apathy. It's kind of, it's really frustrating that these people aren't changing. You may have to push some of the energy up before you can mobilize it to get them to act in a way that is more healthy. And also here, you don't want to rule out exploring other careers. Not everyone has to be a help giver for their profession. Just because that's maybe what they went to school for, what they thought they wanted to do, it really may not be a good fit for them, and that needs to be considered as an option. If they kind of blow through frustration, if they're frustrated long enough, it's likely to lead to experience of apathy. The giving up, becoming increasingly emotionally detached to deal with the frustration, just kind of going through the motions. At this point, they may need to change careers. And it probably will be helpful to kind of explore some of the reasons why they initially pursued this career, and are those reasons still there? And then apathy blends into hopelessness just the longer it goes on. It's kind of hopelessness I think of as a kind of a late stage of apathy. And same interventions here, just harder to do because it's become more entrenched in that feeling of there's nothing I can do. In terms of interventions, excuse me, a lot of the focus is on education. Learning about caregiver fatigue and burnout helps people feel less alone. It's not, oh, I failed and I couldn't do it. It's, okay, everybody feels this at some point to some degree. It's a common experience among help givers. And just doing that in and of itself makes some of their emotional reactions more manageable, and then it's easier to work through some of the stuff once they realize that they're not such a bad person for being frustrated or angry at their clients or feeling like they can't do anything right sometimes. Last, we'll talk a little bit about prevention. As I've kind of said already, education is huge. Obviously, when you're working with them, education, but before that, we can educate people less likely to experience burnout. Encouraging people to have a life outside of work, so that work doesn't become the only thing in their life. That really is important, and especially the interpersonal interactions. Healthy interpersonal interactions are incredibly important in terms of preventing burnout, because a lot of our burnout comes from these intense relational experiences, and you have to have a kind of a think about this balance of bad relational experiences to good relational experiences to have good emotional health. If you're going to have a lot of bad emotional experiences, relational experiences in therapy until you have some breakthrough and maybe have a couple of good relational experiences in there. But a lot of it's going to be some pretty difficult, stressful stuff. You got to have a lot of good stuff outside of work. And then the last thing would be to come up with a decompression routine. Having something that you do between working with clients and interacting with non-clients. So on your way home from work, what do you do to kind of set a clear psychological, physical transition between one world and the other? And that's another thing I'd like for you to be thinking about that we'll talk about in class. Okay? Take care.